Sweet, let's get started. So, hi, I'm Sam Gardner. I'm a recent graduate from the University of Wisconsin, and I've been working with Parker Schwab, a psychiatry resident, and his advisor, David Morrison, to put together an organizational and occupational psychiatry curriculum. And I will be covering parts 1 through 3.
All right, and I'm Parker Schwab. As Sam mentioned, I'm a PGY4 psychiatry resident currently at the timing of making these videos, and I will be covering the last 4 sections of this curriculum. And I'll leave it up to Sam to go through the first 3.
Sounds good. Sweet. So before we get into the presentation, there's just some things to disclose. So we wanted to say that we don't have any conflicts of interest and there are no financial disclosures. And then also throughout the presentation, we'll be using the term org psych. And for the purposes of this presentation, it'll be used to encompass both organizational psychiatry as well as organizational psychology. And there's a lot of overlap with these fields. However, it's important to remember that they are 2 distinct entities. Sweet, yeah. So I'll be walking us through the first part, which is just an overview of organizational and occupational psych. And so in hearing the topic of this lecture, you might have a few questions. You might be wondering what organizational psychiatry is, why we decided to choose this topic, and why is it relevant? Why should I be interested? So our hope is that by the end of this lecture series, we'll answer all of these questions, and hopefully we'll have inspired some of you to learn more, as it's an overlooked and not well taught field, but it has implications for everybody in the workforce. And so we're going to start with a time breakdown activity. So this shows all of the hours across the 7 days of the week. And first, we're going to start with an example of someone who works a typical 9 to 5, 40-hour work week. So we're starting with a blank slate, but of course, everyone needs sleep. So you factor this in 8 hours a night, which I know for some of you watching, that might not be typical, but we'll start there. And so that already takes a considerable chunk out of your free time. And then next, when you factor in 40 hours of work spread across Monday through Friday, you can see that it starts to eat away at free time. And then when you consider a profession that's more demanding, such as healthcare positions, you can see that this drastically eats into free time. And this is not great. This can lead to issues, and it can certainly have an impact on mental health and well-being. And so here we kind of switch from a visual example to give a more concrete view of the breakdown of allocation of time. And so you can see the relative proportions of free time, work, and sleep. And you can see that work, regardless of whether you have a conventional 40-hour work week or you're working in a more demanding position, work takes up a relatively large proportion of your time. And so, of course, this inevitably has an effect on your mental health. And this is really the focus of org psych, is the interplay between work and a career and mental health. And so with that example, we can launch into a definition of what org psych is. So as defined by the Academy of Organizational and Occupational Psychiatry, org psych is a field dedicated to the application of psychiatric principles and practices in the workplace to improve leadership, group interaction, and employee health and performance. And from this definition, you can see that there are kind of two different focuses to org psych. There's the organizational side, where the client is the organization. So this is focusing more on public health, policy, and structure, and how those affect employee well-being. And then there's also the occupational side, where the focus is on the individual. This is looking at the impacts of work on an individual's mental health and how issues with mental health can be navigated in the workplace setting. And so within org psych, there's a range of career pathways that you can choose to pursue. This could be something like consulting, whether that's organizational consulting, focusing on policy development and broader changes within an organization to promote employee mental health and well-being, or it could be something like executive coaching, working with leadership, fostering stronger leaders, which also contributes to employee well-being as a whole. It could be general coaching, or it could be something like doing disability consultations. So navigating scenarios where mental health issues can result in a need for accommodations or leave from work. You can also find a career path in the military. This could be working with leadership or administration, or this could be doing fitness for duty evaluations. So evaluating whether whether someone is capable to serve. There's also career pathways in academics, and these include research, policy, and teaching. And as I touched on a little bit earlier, and we'll get into a little bit later, organizational psychiatry is kind of, I guess, underrepresented in most psychiatry programs. So this is an area with a lot of potential for growth. There's also career pathways in general psychiatry, again, looking at administration or leadership, or work with private or group practice, or work with employee assistance programs. And then in forensic psychiatry, they kind of specialize in navigating disability. So this could be finding accommodations or figuring out leave of absence. They also do fitness for duty evaluations. And then in the last section on psychotherapy, this is looking at the impact of work on self. So this could be looking at an employee's locus of control, or helping to boost an employee's sense of self. And so kind of across all these different career pathways, there's really kind of three durations of org psych work. There's brief work, which are single 1 to 2 hour sessions. And this includes things such as social security, disability, navigating workers' compensation, or doing fitness for duty evaluations. There are medium-term commitments, which could be something like an impaired professional evaluation. So this is looking at professionals who have behaviors or tendencies that are disruptive to the workplace, and then that need intervention and treatment. And this could be pharmacotherapy or psychotherapy. There's organizational consultations and policy and procedure development. And then in the long term, could serve as an in-house consultant, kind of on retainer for an organization, helping them navigate their organizational psychiatry needs. Could work with employee assistance programs, and you could work as a part of crisis management teams. So with a little bit of the context of org psych, we're going to go into some of the history, and this is by no means comprehensive, and the goal is just to provide a little bit of context of the field going forward. So it really emerged in the early 1900s with the development of experimental psychology as a distinct field itself. After this field emerged, industrial and org psych emerged as a subfield shortly after. And then kind of following in 1911 and 1913, there were the first publications on how concepts from psychology could be applied to the workplace. And so in this time period, the focus was really on how to leverage these concepts to maximize worker productivity. So the focus was really on how to help corporations kind of extract maximal usefulness from their workers. And then from the 1910s leading up to World War I, there was significant advancement in IO psych. And part of this was that psych was used to improve soldier selection. And so there was a big focus on it as a field. And then within this time too, the Journal of Applied Psychology emerged. And so then in the 1920s, we saw some of the first studies examining the effects of workplace conditions on worker productivity. So there was the Hawthorne study, which found that worker behavior changes while being observed. So generally, workers tend to work harder when they know that they're being observed. And then there are a few other experiments, studies as well, that were just looking at other aspects of the workplace environment and their corresponding effects on productivity. And then the next big shift came in the 1960s and 70s. And this was a shift to focusing on worker motivation. And this kind of came in tandem with Carl Rogers' work on self-actualization, Maslow's work, B.F. Skinner's work on operant conditioning, and then in this time too, Douglas McGregor put forward his X and Y theory, which is that X assumes that warning and punishment is necessary because at a base level, people don't want to work. And then Y assumes that in a supportive environment, self-direction boosts employees' achievements. And in addition, there was also work done by Frederick Herzberg, David McClelland, and Victor Vroom on worker motivation. And so following this in the 70s and 80s, there was the development of the Handbook and Society of Industrial and Organizational Psychiatry, or Psychology, excuse me. And so this was just kind of putting like an organized professional base into place for research and implementation. And then following this in the late 90s and early 2000s, there was another kind of shift in focus. And this was looking at the result of stress on performance. And it was kind of the first time that the notion of the importance of work-life balance emerged. In addition, there was also research onto the impacts of varying leadership and how innovation and adaptability contribute to the work environment. And then it's worth noting that there was also writing by Sperry, Kahn, Longleb on mental health in the workplace. And so then moving into the present and future, the prominent focuses are really on the impact of automation, big data, AI, how they affect the workplace, their function and their effect on employee well-being. And then we also had the COVID-19 pandemic, which resulted in a large shift to remote or hybrid work. And so that's also something that's relatively new and has implications for employee well-being. And then perhaps in more recent years, there's been the concepts of quiet quitting and the Great Resignation, which again is just kind of a large perspective shift towards work, on the attitude towards work and the meaning of work in life. And then, of course, there's been a big focus on DEI and the role that it plays in employee health and well-being as well. So with some of the context of the history, we can actually kind of start to get into some of the specifics of org psych. And so for getting into the field, it's notoriously not an easy field to break into. And this is for a couple reasons. Businesses are traditionally skeptical of psychiatry. So what benefit does incorporating organizational psychiatry actually pose for the business? What are the costs? Is it necessary? And so it's up to the organizational psychiatrist to be able to concisely and clearly explain the relevance and benefits. And so as a part of this, there are a few qualities that are essential to being a successful organizational psychiatrist. And those are relationship building and trust. Rapport is essential in kind of conveying the importance and relevance of your work. And so, yeah. And so this is just kind of a really brief overview, hopefully giving a little bit of context on the history of the field, some of the directions that it can take you, and some of the considerations when choosing an org psych path. So in the next section, we'll go a little bit further into why org psych matters. Great, let's go ahead and get started. So in case you missed part one, hi, I'm Sam Gardner. I'm a recent graduate from UW-Madison, and I've been working with Parker Schwab, a current PGY4 psychiatry resident, and his advisor, David Morrison, to put together a curriculum on organizational and occupational psychiatry. And this is part two. So before we get into the presentation, again, it's just important to disclose that we don't have any conflicts of interest or any financial disclosures. And also as a reminder, I'll be using the term org psych throughout this presentation. And it'll be used to encompass both organizational psychiatry as well as organizational psychology. And there is a lot of overlap between these fields, but it's important to remember that they are two distinct entities. And so in part two, I'm going to be getting into why org psych matters. Why is it relevant? Why should you care about it? And so in part one, I established or touched on that org psych really has implications for the vast majority of people in the workplace. Inevitably, work plays some role in your mental health. And just to back this up, we have some stats from the US Surgeon General. So at least 76% of US workers reported at least one mental health symptom. 84% of US workers reported that workplace conditions contributed to at least one mental health symptom. And 81% of US workers reported that in the future, they will be looking for workplaces that support employee mental health. So we've established that work has an effect on mental health, but why is this? What are the factors contributing to that? I think largely it boils down to the fact that work is central to your identity. Right? It has an effect on your mental well-being, whether positive or negative. It has an effect on your family well-being, your social well-being, and of course, your economic well-being. And so how is this? In terms of the social aspects, work places you in a social contract, right? It forces regular interaction with others, and creates the possibility of forming strong interpersonal relationships, right? Many people become close friends with the people they work with. It gives you structure, and it can help shape your day and organize the rest of your daily tasks, giving you a bit of direction and purpose. It can allow for expression of aggression, not just in like the negative sense, but in the sense of going out and acting on the world. And it can also help to escape unstable home life. And kind of in line with the social contract, work can create a sense of community and belonging beyond just family and friends, right? It can be meaningful and fulfilling to feel like you're working with others towards a collective effort. And of course, it contributes to social identity. For many people, what they do is pretty central to who they feel like they are. So it's important for social placement, can help you find partners, whether these are just platonic or romantic, and it contributes to your sense of self-worth. And at the bottom of the screen, we have a quote attributed to Freud. He said, "To be healthy is to work and to love." And so we've established that work is influential in mental health, but what are some of the kind of explicit benefits of work, right? Of course, it's associated with better financial status, working, earning money, but it's also associated with improved physical health. It's associated with increased confidence and self-efficacy. It gives you structure and routine to your life. It can help you find feelings of satisfaction and accomplishment. It contributes to identity and sense of belonging. And of course, it can be a pillar for meaningful relationships. And in instances where employees were away from work, whether unemployed or on a leave of absence for something such as disability, return to work within 6 months has been associated with lower rates of anxiety and lower rates of depression. So it's kind of an explicit effect, positive effect on mental health. And then on the flip side of this, what are some of the adverse consequences associated with unemployment? It's correlated with greater morbidity, increased prevalence of psychological problems. It's associated with loss of self-esteem and identity. It can lead to learned helplessness, result in family issues and tensions. It actually increases your risk of developing new health conditions by 83%, and it can lead to premature aging. So while sometimes it seems like it'd be nice to be unemployed, there are a lot of negatives that go with it. And then on top of all of this, unemployment is associated with increased hospitalization due to alcohol, which sees a 20% increase in men and a 40% increase in women. Increased prevalence of traffic accidents, which increased by 40%, and increased rates of self-harm, which increased by 25%. So evidently, there are a number of adverse consequences that go with unemployment. And so the last two slides, we established why working is good and why not working is bad. But of course, it's not as black and white as that, right? There are times where work can be taxing on your mental health, or can be not just taxing, but detrimental to your mental health. And so a prime example of this is burnout in healthcare. So burnout is defined as some combination of depersonalization, emotional exhaustion, and feelings of low accomplishment. And in 2021, 39% of physicians experienced some degree of depersonalization, 27% reported emotional exhaustion, and 44% reported feelings of low accomplishment. And so large contributors to this are excessive medical documentation, as well as complexities in the medical record. It's also worth mentioning that women are at a 56% greater risk of burnout than men, and minority and ethnic groups are at a decreased risk of burnout. And so we've established that burnout is a problem, but what contributes to burnout, right? And I think it can be boiled down to a sense of lack of control over the environment. And this is associated with, increased rates of unprofessional behaviors, reduced motivation, and suboptimal communication with patients. And kind of underlying all of this, the greatest risk factor for burnout in physicians is chronic insufficient sleep. 40% of attending physicians report that they are chronically not getting enough sleep, and 51% of house staff, right? And so this contributes to burnout, but it also results in a 96% increased chance of self-reported medical errors and increases rates of patient complaints. So obviously not a good thing. So what can be done to fight this, right? So as I mentioned, burnout can often be associated with a sense of lack of control. And so doing some things to restore that sense of control can help to combat burnout and, increase perspective and purpose. So some ways to do this are through flexible work and vacation schedules, right? This is giving a little more control to workers, giving them a little more autonomy in when and how they work. It can be done through things such as peer support groups, fostering community and a feeling of belonging can go a long way towards combating burnout. Or it can be combated through things such as mentorship opportunities, which can, help to give a stronger sense of meaning and purpose. And of course, in recent years, COVID just drastically accelerated the rates of burnout in healthcare. And this is largely because the COVID pandemic created an environment where it was extremely high effort, high risk, and relatively low reward. And as a result, this increased emotional and physical exhaustion. It led to feelings of helplessness and lack, or futility and lack of meaning. And many reported feelings of poor employer support, which altogether resulted in more physicians leaving medicine. So obviously burnout is a bad thing. And so here are, I guess, some more ways that burnout can be combated. And this is kind of from a bigger view at the organizational level. So many organizations are kind of reframing their focus, shifting their mission, deprioritizing shareholder value and emphasizing stakeholder value, which considers employees, shareholders, I guess, of course, but also the environment and society as a large. And part of this could be through creating new positions, such as a chief sustainability officer, or increased reporting of environmental, social, and governance metrics, which allows organizations to just better keep a pulse on the feelings of their employees and more impacts aside from just profit and revenue. And so, of course, leadership also plays a role in combating burnout, and strong supportive leadership is associated with decreased levels of burnout. And leaders who practice mentally well habits themselves are associated with increased wellness in employees. And so part of this and many leaders are adopting wellness-centered leadership principles. And so these are kind of based on three main tenets: care about people always, be empathetic, listen to your employees, be a part of the team, recognize difficulties, show appreciation. Another pillar is cultivate individual and team relationships. As I mentioned earlier, developing a sense of community and connectedness can go a long way towards combating burnout. And then the last pillar is inspire change. And so in WCL organizations, there is more of a reliance on intrinsic motivators rather than the carrot and stick model. And so these can be things such as input and feedback from employees, cultivating, a sense of meaning, purpose, giving employees more control and more autonomy in their work, and then focusing on growth and values. And this is in contrast to carrot and stick motivators, such as high patient throughput, focus on RVUs or relative value units, focus on cultivating competition, and the threat of punishment. And so to wrap this section up, just some guidelines for healthcare leaders when considering burnout and trying to combat burnout. It's important to remember that the need for meaning is core to human psychology, right? Meaning and purpose and drive are all important in combating burnout, and failure to recognize this can increase burnout. And then drive for meaning can often be stronger than the drive to avoid for pain. And this kind of goes hand in hand with the first bullet. Having a strong sense of purpose, a strong sense of motivation and meaning in the work that you do can help you get through challenging situations or difficult times, and suffering can be meaningful. And then it's also important to remember that meaning is individual, right? This manifests differently for everyone. What motivates someone to do the work that they do might be different for each employee. And so it's up to leaders to inspire and guide towards meaning. And part of this is publicly acknowledging the difficulties of the job and empathizing with employees. And then lastly, it's important to express genuine appreciation, admiration, and recognition. And of course, this must be self-aware. So we give a quick example, and that's that if you wanted to show support for your ICU team, you might want to do something like send them pizzas, right? But we say go a step further than this. Don't just send them pizzas, say good job. Actually, maybe take the pizzas down, or at least go down and, visit with the employees, be there, be a part of the team, listen to them, hear about their difficulties, hear about their successes. And just, it goes a long way to combating burnout. And so we'll kind of shift tracks now. We've covered why work is important, some of the benefits of work, some of the risks of not working, some difficulties that can come with working and impacts on mental health. And so, we've established that work inevitably has a large effect on mental health. But as I mentioned earlier in this presentation, there's, a relative lack of training programs in residency. So we have some stats from the group of advancement of psychiatry that just kind of reflect this. They surveyed a bunch of residency programs. And they found that 98% of psych residents very strongly, or at least moderately, believe that psychiatry and work are related, right? So that's essentially everyone. But only 15% of residency programs actually offered formal training in work psychiatry. 80% of psych residents very strongly or moderately believed that residency curriculum should include work psychiatry, and only 25% reported that they were moderately or very comfortable with determining accommodations for work. So this just highlights kind of the discrepancy between the applicability and utility of org psych with the relative availability of formal training. So that's part of our hope with this presentation, is to, share a little bit of knowledge and hopefully maybe inspire a little bit of change and, increase prevalence of training programs. And so, we've covered a lot of why org psych matters. And of course, I think it's pretty evident that providing resources to help support employee mental health is a good thing. But a reality for organizational psychiatrists is that they're working with businesses. And so, the concepts of financial viability and revenue and profit and all of those things play a role. So in this section, we're going to be looking a little bit at the financial viability of implementing org psych and some of the social and economic costs of mental health disorders on the workplace. So we'll start with the costs. It was estimated that in 2020, the net costs and losses due to major depressive disorders was $326 billion. This number was $83.1 billion in 2000, and in 1998, 63.1 was lost due to anxiety disorders. And so the reason I give kind of these two contrasting times is to show that there's been a growth in this number, and this growth has outpaced inflation. and it's due to rise in work and treatment costs. So when we actually get into looking at what's comprising these net costs and losses, there's two things to consider. There's direct costs, which comprises things such as treatment or intervention for employees with mental health disorders. And so this is things like, these are things like pharmacotherapy or psychotherapy. And in the year 2000, it was estimated that these totaled to a cost of $26.1 billion. And so that 26.1 makes up part of the 83.1, but you can see it's a relatively small proportion. So where are the rest of those costs or losses coming from? And these come from indirect costs or losses. So these are things such as absenteeism or presenteeism. And if you're not familiar with the terms, absenteeism is just a greater number of missed workdays associated with mental health disorders. And presenteeism is a reduced degree of productivity while at work associated with mental health disorders. So in MDD, both of these are 2 to 3 times higher. MDD was also associated with a 20% performance decrease in physical tasks and a 35% decrease in mental or interpersonal tasks. And in 2020, the mean presenteeism cost due to MDD was just over $5,000 per employee. So I think this makes it evident that there are substantial costs and losses due to mental health issues in the workplace. So on the flip side of this, what do employers actually stand to gain by strongly investing in programs for employee mental health? And so in terms of health savings, MDD remission was associated with a 5% decrease in non-psych outpatient visits and an 85% decrease in the number of hospital days. And panic disorder treatment was associated with a 94% decrease in non-psych healthcare utilization. So you can see that treatment or intervention for mental health disorders goes beyond just the usage of healthcare resources like for those specific disorders. It also decreases just in general healthcare utilization. And in terms of productivity savings, 1 year of MDD treatment resulted in a 25% chance increase of finding or maintaining a job and a 66% decrease in the number of missed workdays. And so the decrease in the number of missed workdays alone is enough to fully offset the direct costs of treatment. And then this, of course, isn't even accounting for the additional savings due to the decrease in presenteeism. And so strong investment goes beyond, it fully covers the costs of treatment and actually creates more value for organizations. And so some studies have shown that there is a return of $4 for every dollar invested in mental health treatment or intervention. And I think this stat is really exciting because it's showing that not only are, org psych principles, not only are they financially viable, it's a financially smart decision, right? It clearly benefits employees, but there's also really strong financial incentives for organizations. And so my hope is that, sharing this knowledge, or at least just this knowledge being out there, means that org psych will kind of spread and become more prevalent across the board. And so that wraps up this section. Thank you so much, and I'll see you in the next one. Okay, sweet. Let's go ahead and get into part 3. In case you missed the first 2, hi, I'm Sam Gardner. I'm a recent graduate from University of Wisconsin-Madison, and I've been working with Parker, PGY4 psychiatry resident, and his advisor, David Morrison, to put together a curriculum on organizational and occupational psychiatry. And this is part 3. So again, just before we begin, it's important to disclose that we don't have any conflicts of interest or financial disclosures. And throughout this presentation, I'll be using the term org psych. And for the purposes of this presentation, it will be used to refer to organizational psychiatry and organizational psychology topics. And there's a lot of overlap between these fields, but it's important to remember that they are in fact 2 separate things. So in part 3, we're going to be looking at all of the components that sum together to set the foundation for a healthy workplace. And to do this, we are going to look at the framework put out by the US Surgeon General. So there's 5 primary pillars of mental health, and it's all centered on maintaining and promoting worker voice and equity. So the first component that we'll look at is the notion of protection from harm. And of course, this is creating and maintaining conditions to support physical and psychological safety. So there's 2 facets to this. There's safety and security. Safety can be things such as protection from harm, both physical and psychological, protection from injury, protection from illness, and protection from discrimination. As well as in terms of security, this can look like financial security as well as job stability, both of which can have implications on not just psychological well-being, but physical well-being. And so some of the key components to ensuring strong protection from harm are prioritizing physical and psychological safety. So it's important to, regularly examine the workplace and make an effort to eliminate threats or hazards to physical or psychological safety. It's also important to regularly design and implement changes to improve safety and protection from harm, and then have regular evaluations of safety. And then another key component is that it's important to enable adequate rest. So as we kind of touched on in our example in the last part on burnout, not having adequate rest is associated with a lot of negative consequences. And this isn't just limited to healthcare. Across the board, non-adequate rest is associated with increased injury and risk of mistakes. Long hours are associated with greater levels of exhaustion, anxiety, and depression. And then fatigue is also associated with lower productivity. And then the last key component in ensuring protection from harm focuses more on, the psychological side, and it's operationalizing DEIA norms, policies, and programs. And so it's been recognized that a celebration of diversity decreases stress and anxiety. And I think this makes sense, kind of as we've looked at in earlier sections. Having a strong sense of community and belonging and good interpersonal relationships goes a long way towards promoting mental health, and promoting DEIA norms and policies and programs is a large part of this. And so it's also important to ensure that these policies are actually in place and that they're consistently enforced. And then, of course, inclusive leadership kind of paves the way for a supportive work environment. So the next pillar I'll cover is the idea of connection and community, right? So fostering positive interactions and relationships to support well-being. And this kind of has 2 dimensions. There's social support and there's belonging. In terms of social support, this can look like having strong social networks and relationships, which can offer you help and support when in times of, physical or psychological need. And of course, decreased loneliness and isolation. And so in terms of belonging, it's important to feel accepted as a member of a group. And again, as I've touched on throughout this presentation, having that sense of belonging and community is vital to strong mental health. So the key components in fostering and ensuring connection and community are striving to create cultures of inclusion and belonging. And then again, this is related to some of the concepts in the last pillar. You want to strive to decrease bias, discrimination, and inclusion. And in doing so, encourage connection, encourage community. It's important to strive to cultivate trusted relationships. So this looks like ensuring clear and consistent communication. And this could be between leadership and employees or between coworkers. And part of this is explaining key decisions, sharing some of the rationale, creating an environment of trust and inclusion when it comes to workplace decisions. And then it's also important to model trust, right? Making a real effort to get to know workers, whether this is leadership getting to know their workers or coworkers getting to know each other. Can bring down maybe some of the initial walls that people have up when first meeting each other, allowing creation of true and strong community and connection. It's also important to foster collaboration and teamwork. And this looks like being intentional when it comes to building teams, intentional in your communications and intentional in your collaboration. And from a leadership side, it's essential to provide effective collaboration tools to encourage this and make it easier for employees. And then it's also important to allow time for non-work connection and service, right? I think it's often these non-work times when you can form the strongest connections with coworkers and really develop a feeling of community and belonging. So the next pillar that we'll cover is work-life harmony, otherwise known as work-life balance. And this is just the ability to integrate work and non-work demands without significant conflict, right? Having strong sense of meaning and feeling and purpose at work, but also having that outside of work. And so the two elements that kind of comprise this are autonomy and flexibility, which are similar and quite related. Autonomy looks like having control over when, where, and how you work. And flexibility is kind of having the ability to work when and where is best for you. And so some of the key components in ensuring strong work-life harmony in the workplace is providing more autonomy in how work is done, right? So having decreased turnover is associated with increased productivity and satisfaction. Having an unpredictable schedule is associated with a number of negative consequences, from economic hardship to tolls on both physical and mental health. And it's also important to not penalize workers when personal needs arise. Of course, this happens to everybody. And the next key component is increased access to paid leave, right? So limited access is associated with a number of negative outcomes, such as infection spread, decreased productivity, burnout, and all of this can ultimately lead to labor shortage. And then on the flip side of this, strong access to paid leave is associated with just general better health, as well as higher employee retention. And lastly, it's important to have strong boundaries between work and non-work. So one component of this could be not penalizing a worker for missing work, whether that's due to personal reasons or whatever reason. And this is associated with lower rates of anxiety. And then it's also important to strive to limit digital communication outside of work hours. So having like a clear boundary, when you leave work, you're truly leaving work and you're able to go home or go wherever and not necessarily bring work with you. The next pillar we'll cover is the concept of mattering at work, right? And this is just feeling like you matter to the people around you, and you feel that the work that you're doing is significant and meaningful. So the two components of this are dignity, which is more of the on the interpersonal side, feeling respected and valued by your coworkers and by leadership. And then there's also meaning, which is more internal, having like a strong sense of the broader purpose of your work and the significance and meaning in what you do. And the key components in ensuring this are at a base level, providing a livable wage, a wage that's equitable, stable, and predictable. And so kind of as an example of this, increased minimum wage is associated with generally improved health as well as decreased racial disparities. And it's also important to employees have easy and strong access to benefits kind of as applicable. Another key component is that it's important to ensure equitable opportunities for engagement. So this could look like, routinely involving employees in kind of the goals and planning and objectives of your work, kind of giving more involvement into like the planning and execution and everything, helping to foster a stronger sense of meaning and purpose. It's also important to measure well-being regularly. So this can be done with surveys or other validated tools, and just allows workplaces to kind of keep a pulse on how their workers are doing and their personal perception of both the meaning of their work and the sense of mattering at work. And then lastly, it's important to build a culture of gratitude, recognition, and meaning, right? So having a shared purpose, working with others towards a collective goal is associated with greater pride, associated with greater, concept of the meaning in your work. greater motivation and decreased perceived stress. And it's also part of this is the significance of acknowledging and expressing gratitude and recognition to the roles of both of individuals, team, and departments as a whole. And the next and final pillar is having the opportunity for growth. And of course, this just means offering routes to accomplish goals and grow skills. And so the two facets within this are learning and accomplishment. And learning is just the process of acquiring new skills and knowledge, and an employer facilitating an employee, wanting to better themselves or learn or grow. And then there's accomplishment, which is the employee's feeling of achievement upon meeting their goals and feeling like they're having an impact in what they do. And so the key components of this pillar are offering quality training, offering educational opportunities, and offering mentoring opportunities. This conveys, a genuine interest in worker development and true, opportunities for workers to grow themselves personally and grow in their career. This also looks like personal encouragement, having access to strong professional coaching resources, and having access to mentorship opportunities. Another key component is that it's important to foster both clear and equitable pathways for career advancement, right? There needs to be a transparent path that someone can follow in advancing their career and being able to, for lack of a better term, climb the ladder, move their career forward, and grow both as an employee and as an individual. And so to do this, it's important to have strong access to resources and tools that actually facilitate and support this advancement. And then lastly, it's important to ensure relevant and reciprocal feedback. So this could be between employees and leadership or between coworkers. And it just looks like providing guidance on strength and growth opportunities, facilitating, advancement. And then this also includes providing leadership training, facilitating strong leaders that are ready to both grow themselves personally and encourage growth in the people who work under them. And so this, wraps up the 5 pillars. And kind of as you can see from talking through each of them, there's a lot of overlap and relatedness and connectedness between them. But if all 5 are in place in a workplace, that kind of paves the path for establishing, a culture conducive to strong mental health. And yeah, so that wraps up section 3. And for section 4, I'll be passing it off to Parker. So thank you.
Hi, everyone. Welcome to part 4 of our 7-part series on organizational and occupational psychiatry topics for residents. If you haven't met me in prior videos, I'm Parker Schwab. I'm currently a PGY4 psychiatry resident at the time of the making of these videos. I do want to thank my assistant author, Sam Gardner, and then my advisor, David Morrison, in helping create this curriculum and these lecture series. So we'll just go ahead and get started. Before we begin, I do want to go over some disclosures. So we don't have any current conflicts of interest or financial disclosures in terms of this curriculum. Also, we will be using the term org psych or organizational psychiatry throughout this lecture series. But please note that this encompasses both topics from psychiatry as well as psychology. These fields often overlap but are distinct entities. So just please be wary of that as we go through this lecture series. So to go over what we've gone through before, so in section 1, we covered what organizational and occupational psychiatry is, just briefly, including a history of the field. In section 2, we went over why organizational psychiatry matters to us as physicians, as well as to our clients and patients. And then in section 3, we went over the U.S. Surgeon General's framework for the components of a healthy workplace. And so this hopefully has set us all up to begin thinking about how we might begin conversations of work with our patients and how to navigate this. And so in section 4, we'll be covering the topic of how to take a work history with our patient and how that might be relevant in our psychiatric discussions with the patient, and then also potentially even the diagnosis. So in general, what is a work history? So it's when we start talking to our patients about their work life, including their developmental history and their history of their career paths. This is really important to have this discussion with your patients because it helps provide information on patient function. In addition, it helps you identify career goals and establish rapport with your patients. It also helps physicians realistically assess patient expectations, their skills and qualifications, which can be helpful both diagnostically and from a treatment perspective. And then also it helps assist with understanding how patients may adapt their perceptions and expectations of their career and their life going forward. So we as psychiatrists are uniquely suited for this role, as we often provide a source of reality testing and integration of the self through various psychotherapeutic modalities and tools. We are adept in listening to our patients, especially when it comes to occupational hopes, and then also integrating these hopes with current realities, which is a large part of what a work history helps us do. And then also we're able to help our patients or clients explore possibilities within their own career and what that might mean going forward. So this is just a general framework of how I think about the work history. I've broken it out into several sections just for ease, and hopefully this makes it a little bit easier to think about. But I first think about developmental history when it comes to the patient's career and work life. So what did their parents do for a job when they were growing up, and what were their parents' attitudes towards work? What were their childhood chores, and what was their work ethic towards their chores growing up? Was it a strict militant household, or was it more kind of free form, do your own thing, be more of an entrepreneur kind of environment? Think about what their goals were growing up. Did they want to be an astronaut, or was it more realistic? And not saying that being an astronaut is not realistic, but for some people that might be hard to achieve. Did they meet these expectations growing up, and what does that mean to them psychologically, and how is that impacting them now? And then also, how does that relate to their first job for pay? What was the job, and what were their reactions like working, and how did they respond, and how does it relate to what their job is currently? You then want to go into a pretty robust description of what their current job is. So you want to ask questions like, where or how did they get their job, and what is their current position and role? What duties do they have, and what daily tasks are they assigned? Are their work hours really long, or are they relatively short? Do they have any effects on sleep? This is critically important when we think about patients with things like bipolar disorder. And then also we want to go into, where does their work come from? Is it something that's from the top down, where a manager will assign them certain roles? Are they able to be more entrepreneurial in their career and kind of find their own projects to work on? What does that mean to them, and how do they relate to that work? And then also, where does their work product go to? Is it something where they just do Excel work all day, and then that goes into a database and it isn't really ever acknowledged by other people? Or is it something where they do grand presentations and have large audiences? How do they relate to that, and does that fit their psychological needs at work? You also want to think about how feedback is given. Is it done in person? Do they feel like they have a good relationship with the person giving feedback? How do they respond to the criticism? Do they feel overly criticized at work, or do they feel like they're able to adapt to any sort of feedback that they're given? And then also, do they find their work meaningful? And also, do they feel like it gives them a sense of purpose? As you know, a psychiatrist, that is really important in a person's psychological life, and can have a lot of implications and or impacts on how they view themselves and their sense of self-esteem and efficacy. You then want to go into their relationships at work. So who works with them? Do they work in teams? Do they like their boss? What is their boss like? And then also who are their friends at work if they have any. So really delving into the interpersonal relationships and dynamics at work, and see how they respond to any sources of interpersonal conflict, which may be important, maybe suggesting an underlying personality disorder or some other psychiatric diagnosis. You then want to go into incentive structures at work. How are they promoted? Can they be promoted? Is their pay going to be docked if they're not doing a good job, which may be more of a competitive work environment, which could present a lot of stress. And then also, do they have abilities to get away from work while they're at work? So being able to take short breaks if things are stressful, are they able to find ways to cope with work while they're in a stressful environment, and how has that been going so far, and how has that impacted them? You then want to delve into their prior work experiences. So what types of work have they done in the past? What was their motivation for pursuing those jobs? What were their expectations of that job, including expectations that were put on them? And then also, did they live up to those expectations, and how do they relate to that? And how does it affect them now psychologically? And how has it affected their sense of self-efficacy and preservation? In addition, you want to talk about transitions in their career in the past. So did they leave a job in the past because they were feeling like they just didn't have enough meaning at work, or did they get let go because they were having poor performance reviews, and what did that mean to them, and how did they go forward from that? How are they supported during those times as well? Did they have a strong support network? Did they have people they could fall back on if they were having a hard time, or did they mostly kind of grin and bear it and just try to get through on their own, and be a little bit more independent with that? And that kind of might suggest maybe what their attachment style is, and kind of how they navigate those areas of conflict in their life. And then also, you want to talk about qualifications. What types of skills and training have they had? What other qualifications or certifications do they have? And that can help you figure out what might be their areas, further opportunities in the career path going forward. And then also, if the patient's having a hard time with employment, or if they're unemployed, it might help you navigate what might be realistic options for those patients to pursue in terms of their career going forward. And finally, you want to think about areas of growth. So if they've had prior negative performance reviews, what were the suggestions for growth or recommendations of growth? And then what areas have they struggled in the past? That can kind of help you understand the dynamics of conflict with them, and then also what might be areas of growth in the future, and then areas that you might be able to target for any treatment interventions. So this is a slide that kind of goes along a different framework using the U.S. Surgeon General components of a healthy workplace. So it's just a little bit of an extension of what we've been working on so far, but choose what works best for you. I'm not telling you there's any perfect way of doing a work history, but these are just ways to start framing how you think about these conversations and how you navigate them with your patients or clients. So if you think about the U.S. Surgeon General's framework, there are 5 pillars. So the first is that purple section of mattering at work. So when you are thinking about asking these types of questions to your patients, you want to dig into dignity and meaning. So asking questions about if they feel respected at work and valued, and do they find their work meaningful. So for the second pillar of opportunities for growth, you really want to dig into if they feel like they have a lot of avenues for learning. How do they go about finding those? If they're available, is that supported at work? Is there clear paths for advancement at work? Or do they feel like they're generally just stuck, which can also have psychological ramifications. For protection from harm, that's digging into senses of safety and security at work. So do they feel physically, mentally, and financially safe at work? Have they been experiencing any discrimination, bullying, or harassment, which is a critical question to ask, as you can help try to navigate any of those conflicts if they are occurring. And then do they have safety supports available at work, and what are they, and how do they how do they use those resources if they are available. For connection and community, which is the blue section, you really want to ask if they have a strong support system at work, what it's like, who they can go to if they're having a hard time. Do they have a mentor? If they don't have a mentor, what are the options? Which also kind of plays into the opportunities for growth. And then I think most importantly, or maybe not most importantly, but an important thing to also ask is if they feel accepted as part of the team, because we know that isolation and loneliness can lead to a lot of depressive disorders. So if they don't feel like they have a strong support network, that might be a strong source of feelings of isolation and loneliness. And finally, but not least, work-life harmony. So thinking about autonomy and flexibility. Does the patient or client feel like they have control over when and where and how they do their work? They have access to paid leave if they need it. And then also, are they able to establish firm boundaries between work and home? And if they are able to, have those ever been infringed upon? Does their boss often ask them to do work outside of normal hours? And if so, how do they navigate those conversations? And you may be able to help them navigate those conversations as well. So that does conclude this section. It was a little shorter. I hope it was helpful to think about maybe how to start navigating those discussions with your patients or clients on the work history and how it might be impacting them, as it will, I think, give you a lot of valuable information into what might be going on with them psychologically, and may help with diagnosis as well, and will allow you to more fine-tune your treatment plan for the patient or client. So with that, I will conclude this section and we'll move to the next part 5. Thanks. Welcome to part 5 of our 7-part series on organizational and occupational psychiatry topics for residents. If you haven't met me already, I'm Parker Schwab. I'm one of the current PGY4 psychiatry residents. At the timing of these videos, I do want to thank my assistant author, Sam Gardner, and then my advisor, David Morrison, for assisting with creating this curriculum. Before we begin, I do want to go through some disclosures. We currently don't have any conflicts of interest or financial disclosures at the timing of making these videos. In addition, we're going to be using the term org psych or organizational psychiatry to encompass both psychiatry and psychology terms and topics. But please note that these fields are distinct and often overlap, but to be mindful of that as we go through the lecture. So in section 1, we went over a brief overview of organizational occupational psychiatry, what it is. And then in section 2, we went over why it matters to us as physicians and then also to our patients and clients. In section 3, we went over the U.S. Surgeon General's framework on the components of a healthy workplace. And in section 4, we went over how to take a work history of our patients. And today, in section 5, we'll be going over treatment plans. But before we get to treatment plans specifically, I do want to talk about how if a patient experiences a job loss, that should be considered a psychiatric emergency. And during that time, we have 4 essential tasks. The first would be to triage and treat emergencies, so screening for things like suicidal thoughts, or active suicidal thoughts, homicidal thoughts, or escalating substance use, which may require urgent treatment. Once we've done that, we want to treat symptoms medically and psychotherapeutically. As part of this process, we want to help patients recognize their own vulnerability, identify feelings, and enhance their support system. Psychotherapy may be an important modality in their treatment. In addition, we want to help them realistically evaluate job prospects and assess their current workability, including potentially even thinking if they need to take disability, if there are any mental health disorders that are currently impairing their ability to work. When it comes to mental health in the workplace, the CDC has several recommendations, both from a provider standpoint and from an employee standpoint. So for providers, they recommend that we screen for symptoms, offer treatment, and connect our patients with services as appropriate, including referrals to psychologists, social workers, physical therapists, or occupational therapists, and other practitioners as needed. From the employee standpoint, they recommend that our patients encourage their employer to offer mental health resources, participate in these resources if they're offered by their employer, and then also serve as wellness champions for others that are experiencing something similar. Oftentimes, this is recommended maybe to be outside of their own workplace because it can be pretty sensitive to disclose some of their mental health issues at their workplace. But when they do become a champion, they encourage them to share personal experiences to reduce stigma around mental health issues, offer peer support, encourage others to seek support, and then also practice empathy with those individuals. In addition, they recommend that the employees adopt wellness behaviors, including healthy diet and exercise, maintaining good sleep hygiene, meditating and practicing mindfulness, and then also making sure they're socially engaged. The World Health Organization also has several recommendations when it comes to mental health in the workplace. They mostly focus on from the employer side. So they state that an employer should offer reasonable accommodations for mental health, including flexible hours, extra time for appointments or extra time on projects, support from their supervisors. In addition, they recommend that they offer return to work programs and clinical care access, which has been shown to be associated with reduced mental health symptoms. And then they recommend that employers offer supported employment initiatives to provide continued mental health and vocational support. So from both the CDC and the World Health Organization, these are great guidelines that we can point to from the practitioner standpoint to advocate for our patients, especially if they're experiencing a workplace that's not offering these types of resources. We can point to these specific things to say, hey, this might be something that you should get your employer to offer, or we can even go to the employer directly and ask them if they're able to provide these. So when it comes to treating our patients for mental health disorders, I like to come at it from a lens of maybe becoming a coach for our patient with the goal of optimizing wellness and life balance. We're uniquely suited to help our patients assess their goals, explore past meaningful experiences, discuss their skills and talents, and then also explore their home life and what that might mean to them. And this makes us uniquely suited to try to help them navigate this environment and identify new goals and pursue those goals, and maybe find new areas of growth. So I won't belabor all of this because I know most of psychiatric residency or psychiatry residency is about diagnosing and treating mental health disorders, but it is important to just note that we as practitioners are required to screen, diagnose, and treat mental health disorders, anywhere from mood disorders all the way to personality disorders. This encompasses all of the DSM diagnoses. I won't go through these in detail, but I did put them here for reference. Again, this is not an exhaustive list of mental health disorders, but ones that we commonly see in practice. I broke it out into the various categories and proposed interventions. Again, this is non-exhaustive, but it might be good places to start. I won't go through all of these in detail, but each disorder category does have some general recommendations, which might be something to think about, or an area where you can at least begin with your patients. The one thing that I do want to point out specifically is that when it comes to work, we have other things that we want to explore with our patients when it comes to treatment options. So we really want to think about screening for time management issues. So asking questions about if the patient's meeting deadlines, if they're requiring extra time at work, if they're having a lot of distractions at work. If so, potential intervention would be to limit time on social media or other avoidance behaviors that might be going on. Maybe recommending that they set specific wake-up times and work-in times to constrain their work to specific times during the day so that they can be more focused during that time. If they're having a hard time with work-life balance or finding meaning in work, maybe recommending that they try to explore their hobbies or interests and scheduling more time for those outside of work. Also encouraging time with loved ones, and also talking about trying to exercise regularly and maintain a healthy diet, which all can be important things to help with mental health symptoms as well. I think one important thing to point out here is that it's critical to screen for food and housing insecurity as well, as that can be an important area of distress or source of distress for people. So you want to ask them questions that help identify if they're having any difficulties with finding a stable income source, if they have any disposable income, and if so, how much, if they're having issues with transportation, if they have dependents or a number of dependents that they have to support, and then also if they live in like in a food desert. And the main treatment intervention here is to know about local resources and offer them as available to the patient. So that was a very brief section, but hopefully it kind of got you thinking about the additional things we want to think about when it comes to work and treatment options. I didn't go through all of the treatment options for the various psychiatric disorders because I know that we get most of that in training and it was a bit out of the scope of this presentation, but hopefully it was helpful for you. And now we'll move on to the next section. Welcome to part 6 of our 7-part series on organizational and occupational psychiatry topics for residents. I'm Parker Schwab. I'm a current PGY4 psychiatry resident at the timing of this video. I'm going to thank my assistant author, Sam Gardner, and then my advisor, David Morrison, on helping complete this curriculum and mentoring me through this process. So we will go forward. Before we begin, I wanted to just note that we don't have any conflicts of interest or financial disclosures at the timing of creating this curriculum. We will be using the org psych term to both encompass psychiatric and psychology topics. But please note that these are distinct fields. However, they do often overlap. So just to keep that in mind throughout this lecture series. So this is a bit of a bigger topic today to cover. So I've actually split it out into 4 different sections. It's going to be a bit longer of a video today because it's just a lot to cover, and this is probably the bulk of the material from the lecture series. So the first section is on disability and impairment, what it means, and kind of the definitions. The next section goes over leave of absence considerations if a patient is coming into you asking to take off time at work. And then we'll go over basic FMLA evaluations and what those look like and the considerations of that. And then we'll get into more advanced evaluations that require a little bit more robust evaluations, diagnostics, and then more formal written documents for legal proceedings that most psychiatrists don't do. They often refer out for these types of evaluations, but some do get training in this. So just to briefly go over disability and impairment, this slide is just to show that there's numerous definitions of disability from different organizations. I'm not going to go through all of these in detail for purposes of time, but we'll focus on the ADA as that impacts most of our patients in the United States. They defined disability as physical or mental impairment, which substantially limits one or more major life activities. These next couple slides are there to help us kind of understand what disability and impairment are and kind of the differences between the two of them. So disability is actually administratively determined based off of provider impairment descriptions. So as a provider in psychiatry, we actually are commenting on impairment and not disability, as that's determined by a judicial decision. But the World Health Organization does define impairment as loss or abnormality in a person's psychological, physiological, or anatomical structure or function. So the framework to the right, or the schematic to the right, just kind of goes through and shows you that at the top, disability is determined by an administrative or judicial decision. There are 2 main components to this. One is the finder of fact, which is either a claims administrator, judge, or judicial tribunal, which then helps determine disability. And then there's the psychiatrist or other expert that's offering opinions on impairment that are resulting from psychiatric conditions that's then used to determine disability. If we are the provider offering opinions on this, we always have to provide an opinion on whether there's a causal relationship between the injury and the psychological condition. And we also have to opine on whether or not the impairment is either temporary or permanent. These next couple slides are tables that go over various definitions from the American with Disabilities Act. I'm not going to go through these in detail, but they're here for your reference. I do find that they're pretty helpful. So as you go through this, going back and maybe reviewing this would be a good thing to do. This next slide is more of a graphical representation of kind of what those tables before were commenting on. So I felt like this might be a better slide to cover than all of the words of the previous slides. But with the American with Disabilities Act, I tend to think of it in terms of two broad categories, either employed patients or unemployed patients. So if you have an employed patient, they're covered under the Family and Medical Leave Act, and then also can be covered under short-term and long-term disability insurance plans under FMLA. That does protect the patient from being fired for up to 12 weeks of unpaid leave. Short-term and long-term disability can protect an employee's pay when they are taking time off, and potentially could even extend to longer periods of time, greater than 12 weeks, depending on the individual policy in place. But do note that each individual policy, it can be different, and so you would have to look at the terms of each disability plan that the patient has. One thing to note here is that it's always the employee's responsibility to work with their HR departments to sequence FMLA, short-term disability, and long-term disability while they're out of work. It's not necessarily on the provider, and so it's really up to the provider to remind the patient that they are going to be the ones that need to coordinate this. It's just fairly impossible for us to do on the physician end. And then the employer is always encouraged to provide reasonable accommodations if they're able to allow continuation of the job by the patient. If the patient's unemployed, they're covered under the Ticket to Work program and the Job Accommodation Network. These are things that were established by the government that provide employment networks and vocational rehab programs that may be available to your patient if they're unemployed. So always discussing those options with them if you feel like it'd be beneficial. And that these programs also protect Social Security benefits as they are going through those programs. In addition, unemployed patients are covered under the Social Security Act. This determines eligibility for Social Security benefits. And in order to be eligible for those benefits, the condition must prevent normal work. It must be expected to last more than 12 months or result in death. And the patient can't perform any substantial gainful activity doing other work. And the definition of how much they're allowed to earn in order to be considered substantial gainful activity is on the previous slide. So that would be useful to review on your own. The next slide is more of a graphical representation of the types of disability evaluations. The first being FMLA, which we just kind of went over how it protects time, not payment, and it's usually 12 weeks rolling unpaid leave. The next ones are Social Security disability insurance evaluations, fitness for duty evaluations, private disability, personal injury, and workers' comp. The ones that are outlined in the orange box are not required to have a determination of cause. And then the ones in green, so personal injury and workers' compensation, do require a determination of cause. So those are a little bit more advanced and require kind of more of a robust evaluation. And then I outlined all of the ones in the dotted red line or dotted red line box are evaluations that do have the possibility of litigation. So although some providers are familiar with and feel comfortable with doing things like private disability evaluations or social security disability, just be mindful that sometimes those will come back and you might have to provide a more extensive evaluation if the judge or the legal teams require it. So there are many limitations to leave and disability evaluations, the first being access to care. So there's limited participation of physicians in disability evaluations because we just don't get much training and doing these types of things. There's also language or ethnicity barriers more common in rural areas, which may make it hard to do some of these evaluations. There's insurance issues as conditions developed on the job are routinely excluded from insurance coverage. And then psychiatrist training is pretty poor in this area. It often requires a forensic fellowship to gain comfort in doing these types of evaluations. When it comes to leave, there are many things that we want to consider for our patients. I think the best way to go through this is maybe through a case study. So hopefully it will pop up. It's been running a little slow right now. All right, so this is our case. This is Hope. She's a 35-year-old single mom. She says, I'm too depressed. I need to take time off work. She's been having some escalating depressive symptoms over the last 3 to 4 weeks, including worsening mood, anhedonia, avolition, increased sleep and appetite. In the setting of a recent separation from her partner, increasing demands at work, and child rearing responsibilities. It hasn't reached the point of active suicidal thoughts, but she has had passive death wish at times. She does feel like this is consistent with prior depressive episodes, but may be a little bit more severe than it used to in the past. Her past psychiatric history includes depression and anxiety managed by her PCP. She's had no hospitalizations, no suicide attempts. She's not currently connected with a therapist and has no prior psychiatrist. She has a medical history of hypertension. Her family history includes a mother with depression, no suicide attempts in the family. Her social history includes a bachelor's in political science, she works in human resources, has recently been given increasing responsibility due to a company acquisition. She's a single parent to a 3-year-old daughter. She lives in an apartment downtown, in downtown Chicago with her daughter. She's currently on sertraline 50 and amlodipine. All right, so what should we think about with Hope's case and what should we consider with her taking time off work? So the evidence does support that the default should be keeping patients at work unless there's a clear plan to return to work quickly and at full function. They've shown that keeping patients at work is associated with the best outcomes. There's a pretty staggering statistic out there that the odds of returning to work within a patient's lifetime decreases to 50% at 12 weeks of being out of work, which I think is wild. They've also done a study that have shown that 60 to 80% of US lost work days is not related to any specific condition. And from a psychiatric point of view, there's really a few absolute contraindications to being out of work. Those include things like active suicidal thoughts or homicidal thoughts, and then substance use disorders requiring urgent interventions. The key takeaways to taking time off work or considerations of leave include that separation from work can actually be an urgent situation and is associated with poor outcomes, as we went through in previous sessions. Work is often an integral part of a patient's functionality. It can be a source of pride, relationships, and identity. We should always default to keeping patients at work and returning to work as quickly as possible when we're able to. It is noted that leave is often sought due to interpersonal difficulties or hostile workplaces, which might not necessarily be a reason to take time off work. It might be more of an HR thing to handle. The role of the physician or us in this situation is to help the patients navigate these difficulties and try to figure out what would be best for them going forward. back to our case. So after careful consideration of the risks and benefits of a leave of absence, you agree to allow Hope to take time off work and focus on her recovery from her depression. She asks you to complete FMLA paperwork for her employer, and you grant her leave. And then when she does ask you to complete the paperwork, what are the key things to consider with this? So this leads us into basic or FMLA evaluations. So one thing to note is that outpatient providers are often asked to perform disability evaluations for mental health conditions. The American College of Occupational and Environmental Medicine acknowledges that there's a lack of scientific literature regarding work evaluations. They've done prior reviews of disability evaluations and note that there's limited, or there's low inter-rater reliability, and there's variable methodologies out there, which makes it fairly poorly generalizable. Notably, psychiatric disorders, including chronic pain, are now the leading cause of disability worldwide. And this has been going on since 2001, when the World Health Organization named major depressive disorder as the leading cause of global disability, ages 15 to 44 years old, and that's still true today. So when we're thinking about disability evaluations or impairment evaluations, there are several guiding principles that include each individual is different, and that we should always focus on functioning over symptom relief, and that there may be some residual symptoms when the patient is at work, and that's okay. The patient should not be labeled as categorically disabled, but that they have specific limitations and specific contexts. Our focus should always be on work-oriented rehab or rehabilitation with tailored problem-solving strategies. We should work in multidisciplinary teams to optimize functionality as able. We always want to remember that return to work is an iterative process, and it's aimed at restoring function in a stepwise process. And then we always want to maintain objectivity when we're doing these types of evaluations with our patients. The number one thing here is that we always want to avoid medicalizing non-medical issues. So that includes things like workplace conflict, job dissatisfaction, or family strife, so things happening outside of the workplace. It's most notable that, or they've had studies that have shown that over 50% of leave has actually been taken due to non-medical issues. So we've vastly been over prescribing time off work for people when there could have been various other interventions that we could have offered that might have been less damaging. So if these are happening, we always suggest that the patient approach HR to help figure out if there are accommodations that can be offered at work to help them navigate these issues. And it might not be that we need to necessarily step in from a psychiatric standpoint, but we can always advocate for our patients if needed. When we're asked to do the evaluations and we've determined that this is a medical issue, we always first want to clarify what the employer requests. Notably, a patient can qualify for Social Security benefits with any DSM diagnosis if their symptoms are persistent and impairing. The caveat to this is that this does not apply to substance use disorders, so that's an important thing to note. We don't have much objective data to go on when it comes to our diagnoses, so we're often having to correlate symptoms and impairment with our mental status exam, so that's going to be an important thing to focus on. And then we also want to focus on performing an HMP with a focus on limitations on functioning. So in order to do this, you can always ask about the patient's day in a chronological fashion. You can ask for performance appraisals from HR if needed, and then you can also always get collateral from family and friends to help corroborate the things that you're hearing from your patient. You can refer to a specialist for additional evaluation if needed. This includes things like PT and OT, or a neuropsychologist, or a specialist in occupational psychiatry. And also at the core of all of this is that you want to really think about how the results are going to affect the patient. So being labeled disabled or on disability can really create a core belief in a patient that they may never actually return to work, and that can be potentially damaging. So we want to be cautious in navigating those discussions, and even in our consideration of if we want the patient to take time off work. In addition, you always want to think about how this might affect the employer. It might be that the patient requesting certain accommodations or taking time off may be viewed as a nuisance, and they may find these things or these requests unreasonable, and that might risk termination. So we have to be very mindful of the delicate balance that we've been asked to navigate. Thank you for your patience. It's been the slideshow is just kind of lagging behind. These next couple slides go through some helpful tables that I feel like will be good to go over. So the first is various symptoms and how to think about it in terms of looking for it on the mental status exam or asking about history questions in terms of like cognitive domains, affective domains, and interpersonal domains. I won't go through this in detail, but it's a helpful thing to go through if you are doing this type of evaluation, as it can help you kind of figure out what to be looking for. The next slide is actually a flow sheet or flow chart that was developed for primary care physicians in terms of doing disability evaluations. I think it also applies to psychiatrists here as well. So if a patient requests a disability evaluation, the first thing you want to think about is if you're the patient's long-term or longitudinal care provider. And if not, then you always want to think about referring them to the longitudinal provider, as they would be able to know the patient a little bit better and opine upon or comment on more longitudinal data that might support the patient's disability or impairment. If you decide to do the evaluation yourself, you always want to clarify what is needed, including forms like FMLA forms, employer specific forms, any short-term disability, long-term disability forms. If you don't feel comfortable doing the evaluation, you can always refer to a licensed occupational medicine physician or an independent medical examiner. People specialized in this and have done specific training to do these evaluations. If you do feel comfortable doing these evaluations, it would be helpful to schedule separate appointments for work-focused assessments, for discussions regarding return to work, and then also treatment options, because this usually takes a little bit longer of a time and it's hard to cram into a regular session with a patient. In addition, after you do determine if a patient meets criteria to take time off work or is impaired, then you would always want to schedule follow-up to assess the accuracy of your diagnosis, any progress towards treatment goals. If there are work accommodations that you offered that whether or not they've been helpful or not. You also want to consider additional referrals if needed, and then also reassess the timeline of their return to work, and if that needs to be extended or shortened. Here's a list of additional referrals to consider, including PT, OT, neuropsychological testing, IOP programs, any vocational assessment or counseling resources out there, return to work programs, psychiatry evaluations, which we would be doing, and then also occupational medicine if needed. So here are a couple example accommodations you can request from employers if patients have specific symptoms. So for fatigue, you can ask for increased time for breaks, asking for more flexible work hours. For issues with sleep, you can ask for limitations on rotating and night shifts. You can try to help patients coordinate their work with their sleep schedule. For panic symptoms, you can ask for an allowance of 5 minutes for breaks on every hour for on short notice. For irritability, you can ask for more focus on projects. You can ask for limited work or limitations on working directly with people. For hallucinations, you can also ask for the use of headphones, which a lot of people have found helpful. For concentration issues, you can ask for verbal and written instructions, increased time for learning. You can ask for limitations on distractions in the workplace, checklists, if able, and then more defined priorities at work. For work anxiety, you can ask for more flexible hours, routine debriefs with supervisors, and then increased time for mental health follow-up. So back to the case. Hope does not feel like she would be able to return to work with accommodations due to the severity of her depression, and your mental status exam confirms this. You make the recommendation for Hope to start a PHP program next week and then transition to IOP for treatment for depression while she's out of work, and she agrees to this. So how can you best navigate this discussion with Hope? When it comes to return to work discussions, it's noted that this is not an exact science. Studies have shown that most patients do end up returning to work within weeks to months, which is fairly encouraging. You can always offer the return to work as a range, for example, like 4 to 8 weeks, and then revise as treatment progresses. And then also always remember that this is an iterative process requiring communication and follow-up with your patient. So the schematic to the right or the graphic to the right just shows that when we're thinking about effective return to work discussions, we always want to draw on the patient's abilities, resilience, and values. We don't want to focus on limitations. We always want to work collaboratively toward a goal of returning to work with our patients. And then we always want to have good communication with both the patient and the workplace. And when possible, working with multidisciplinary teams to increase patient functionality. When it comes to talking about returning to work, setting expectations early is key. You always want to ask if the patient does expect to return to work, because that can help identify those at risk for delayed return. And then you also always want to ask about the level of self-efficacy that the patient feels at work, as this can also be an adequate predictor of time. In addition, there's a couple other strategies that you can do, including normalizing and validating the circumstances and emotions of returning to work, which may increase their sense of self-efficacy. You always want to normalize that symptoms don't actually equal impairment or loss of function, and that symptoms at return to, or residual symptoms at return to work are actually expected. You can also offer accommodations in lieu of time off when possible, which we discussed previously. You can also always talk to them about their performance reviews. If they're getting all positive performance reviews and they still feel like they're not doing well, this may signify that there might actually be a decreased level of self-efficacy or self-esteem. You always want to offer realistic reassurance and encouragement to your patient. You want to validate their fears of staying at work and help them navigate interpersonal issues at the workplace or home if those are going on. And then you also want to validate that the workplace is not an easy place to return, and that they will be able to do it, but it may be difficult, and things will improve over time. You want to empower them to problem solve and confront avoidance patterns. You always want to try to encourage them to see themselves at the center of the initiative. And then if needed, you can always refer them to a therapist. And in fact, in a majority of these cases, it probably would be helpful for patients to be seeing a therapist during this time. This again highlights that setting expectations early for symptoms and recovery is key. So the goal of treatment should always be returning to work as soon as possible. You want to target work-oriented interventions from the outset if able, including working with the HR department or the company if they're available. You want to normalize residual symptoms at return to work as expected, as we talked about previously. You also want to help patients realize that work may help them alleviate residual symptoms. And then always remind them that resting at home is not always beneficial to recovery. It might actually, in fact, be detrimental. There are several factors that are associated with patients returning to work earlier. Those include an increased sense of self-efficacy, active coping skills, lower age, increased communication with their supervisor, quality and continuity of occupational care at their employer, and then also their own motivation to return to work, which is a little bit self-explanatory. There are several things that are associated with later return to work, including depression, anxiety, comorbid mental health issues, higher age, lower levels of education, prior sick leave or extended leaves of absence, increased job stress, including recent reorganizations of the company, the threat of job loss, and then part-time work. All of those are associated with later returns to work. So just to be mindful of those. So the key takeaways for basic evaluations or FMLA evaluations, the goal is to return to work as early as possible, and that we can always offer accommodations if needed in lieu of taking time off. You always want to start the conversations around return to work early and reassess frequently and set clear expectations with the patient. If able, you always want to schedule separate appointments just for work evaluations and paperwork with the patient so that there aren't any surprises and that you have adequate time to address any questions or concerns and do the full evaluation. It's always okay to leave things blank. You don't want to fill out anything that you're uncomfortable with. In addition, we want to avoid medicalizing non-medical issues. And if that is going on, then we want to have them approach HR. And then if the patient's taking time off work, they should always be actively working on their mental health because just staying out of work is actually not helpful for mental health. It may actually be counterproductive and detrimental. And so you want to think about maybe having them do a PHP IOP program or increasing the frequency of their appointments or therapy visits while they are taking time off work. So going back to the case, you set clear expectations with Hope, you communicate with her regularly, and you have clear documentation on all treatment expectations and expected dates of treatment and return. She completes the PHP IOP program after 8 weeks and returns to work without issue at the agreed upon return to work date. And she feels much better and thanks you for your time in this difficult time. So a pretty good result here. And the key was that we had clear communication. We set expectations for return to work early, and we had her do active treatment for her mental health when she was out of work. So moving on to more advanced evaluations, this is probably a topic that most of you might not do. So if you do feel like you're not going to be a provider that offers more extended disability or impairment evaluations, you can probably sign off now. But if you are interested in more, that you're more than welcome to stay on, and I'll go through some of the more advanced techniques. This is just to, again, describe how after FMLA, most of these evaluations do have the possibility of litigation. And so you want to start thinking about them in a little bit more of a robust way and have more of a strategy as how to approach these. So going forward, when do you want to start considering doing an impairment evaluation? So first, you want to think about the priority being their returning to the job of injury. So you should always make sure that your reasons for a patient taking leave should be based on objective determinations. This can include things like physical evaluations from PTOT or neuropsychological evaluations. If they're not able to return to their job of injury, are there any transferable skills? Can they participate in training? Or are there other prior experiences in a closely related job that they can go towards? If they're not able to do that, are they able to explore options for gainful reemployment? Can they complete any additional degrees or certifications that might make them more employable? Or can they complete vocational programs? If they're able to do any of those things, you can always consider having them take off time for leave, such as FMLA or short-term disability, to provide time to complete these items. Otherwise, if they're not able to do these things, then that's when you really want to start thinking about impairment and doing a full evaluation. So when you do more advanced evaluations or impairment evaluations, what do these look like? So forensic disability assessments incorporates the following: robust clinical psychiatric interview, comprehensive record reviews, job descriptions and job analyses, collateral, and then also psychological and medical testing as needed. Before we get to all of the schematics of how you actually do one of these evaluations, I do want to highlight that there's actually no formal requirement or specific training for disability evaluations, but experience is beneficial. Your skills and diagnostic acumen improve over time, and as you gain experience, there's less influence from countertransference in these evaluations. You always want to be mindful of ethics and self-monitoring. So if you're doing an evaluation, you want to think, is my opinion consistent with past similar circumstances? Do I feel comfortable defending this in front of a jury? Is there anything in the evaluation that doesn't feel right or doesn't pass the smell test? And those can be all things that are red flags for you to maybe hold off on the evaluation or reconsidering. So there are several requirements for individual medical evaluations or individual medical examiner evaluations. One being vocational review. So this includes describing the physical, mental, and mental activities associated with the job. In order to do this, you can always employ the Fischler and Booth vocational impact of psychiatric disorders as a good resource that describes each diagnosis' impact on work functionality. You also have to go through a full impairment description, which includes whether or not the condition is sufficiently severe enough to preclude gainful employment, whether the examinee can perform some functions and not others, and that includes descriptions of limitations, which is the activities that the examinee cannot do, and then also a description of restrictions, which are activities that the examinee should not do. In addition, you have to provide impairment ratings, and so these must be provided through a dimensional impairment rating according to statute criteria within the individual states, and then also the AMA guidelines, which we will go through. It is important to note that the impairment ratings are often inconsistent between examiners due to lack of training and research, and also just the confusing legal landscape. But it is important to try to triangulate or cross-correlate multiple rating scales to try to make your evaluation more consistent, which we'll go through in more detail. So for dimensional impairment ratings, cross-correlating multiple rating scales and psychological tests will improve your consistency and reliability of your court testimony. One of the main psychological tests that is currently employed most frequently is the MMPI-3, as that is generally believed to meet the standard in forensic testimony, or for the standard for forensic testimony, and we'll go through that a little bit more in subsequent slides. But when it comes to cross-correlating multiple scales and definitions, you want to look over the various definitions that are provided in the AMA Guide to Evaluation of Impairment. You also want to look at your own individual state definitions. For example, Washington State has the categories for evaluation of permanent impairments of mental health. So you can always use that to help cross-correlate, or you always can use that to cross-correlate with the AMA Guide. And then also you want to use your psychological testing results to cross-correlate as well. So what is the role of the independent medical evaluator for a psychiatrist? So when you do these evaluations, you always want to be the independent seeker of truth. You want to offer unbiased opinions. You always want to avoid establishing a doctor-patient relationship or act as the treating clinician, because that could always create conflicts of interest. In addition, you want to provide early notification to all parties with clear and substantial reasons if any exceptions are made. When you become the independent medical evaluator, these are often requested either routine or requested by the litigator, such as the attorney, insurance providers, or employer or government agency. The claims manager often requests updates in half-year to 1-year intervals. When you do get an IME request, it should include an assignment an assignment letter, which defines the purpose of evaluation, the questions that need to be addressed. If this is not provided, you should always ask for one, as that will help decrease the chances of any misunderstandings. The requester is going to, well, the requester should provide records necessary for evaluation. It's the examiner's responsibility for requesting any missing records. And if there are any critical missing records, it needs to be adequately reported in the report. As always, it's really important, or you have to discuss informed consent with the patient, any restrictions of release of the documentation. And then also, it's important to discuss your fee arrangements prior to the evaluation. This goes through various disability evaluations in some detail. So the first one that we'll go through is workers' compensation. This requires an apportionment of causation between the workplace and unrelated factors. You have to include severity ratings, both pre and post-injury, according to statute. There's a degree of restriction. You also have to comment on the degree of restriction to perform duties without accommodation. You also have to assess if there's either permanent or temporary impairment, and also describe limitations and restrictions. You also have to provide treatment reports every 60 days to insurance companies, and that you have to remember that patients are always entitled to this, any correspondence between the insurance company and the provider. Moving on to fitness for duty evaluations, this is required when there's a question if a patient is able to perform their job safely. Referral letters outlining the reasons for evaluation and questions to answer is required. So if you don't get that, you need to make sure you request it. And these evaluations, you're usually not required to do a developmental history unless it's relevant, which is in contrast to workers' compensation and social security evaluations. Remember that fitness for duty evaluations are profession specific. So for example, a law enforcement agent or a law enforcement employee is going to have a different evaluation than, say, a physician. There's always potential for misuse by employers. So if you do feel like there's a suspected hidden agenda, then you want to always decline the request to do an evaluation. For Social Security disability, this is administered under the Disability Determination Services branch of the Social Security Administration. This typically acts as a backup benefit for workers' compensation. The Disability Determination Services Agency will supply records for review. This is often less complex than workers' compensation. It doesn't really require a determination of causation, and generally testimony is not required. You do, however, have to provide an opinion on the duration and prognosis of treatment and the ability of the patient to manage funds. And then if this is denied, it can always be appealed. There may be additional psychological testing that is ordered by the judge or attorney. They look for opinions on if the claimant meets the definition of mental disorders. And these definitions are similar to, but not identical to the DSM. In fact, they're contained in the Social Security Blue Book and Psychiatric Review Technique form, which is all available online. If the patient does meet criteria for a mental disorder diagnosis, then a mental residual functional capacity assessment is completed. Again, these are all if the Social Security disability evaluation is denied. Often all of these things are required in the appeal process. So if you are appealing and you do require a mental residual functional capacity assessment, I'll go through that in the slide. So the MRFCA lists 20 mental capacities across 4 different categories of mental functioning, including categories of understanding and memory, sustained concentration and persistence, social interaction and adaptation. I went over a little bit of these more in detail in each box, which I won't get into right now just because of time, but please review those on your own. And then in addition to doing the assessment, you have to comment on the severity using the 5 severity ratings listed below. So it's a bit of a of a robust evaluation and may require some practice with it, but hopefully it'll be fairly straightforward. So now we're getting into how to actually do the interview with the patient and what's required in the evaluation and report. So in the report, there's an introduction. You have to include demographic data, including age, gender, ethnicity, marital status, members of the household, statements of non-confidentiality, and then informed consent, and also the chief complaint. You have to comment on your records review, which details the records or documents that were reviewed. This often requires recording the relevant facts of the document line by line, and it can be quite tedious. And then just noting that sometimes the evaluation may be determined inadequate if every page of the record is not read. So it does require you to read every single page of the reports that are given to you. You then have to go through a full employment history, which includes elements central to the personal functioning, impairment, and disability of the person. You have to comment on jobs previously held, any changes, promotions, or dismissals. This can often help reflect the patient's aptitude, adaptability, and capacity to take orders, ability to cooperate, and any leadership capacity. In addition, you have to comment on medications, including current and past medications, prior diagnoses, side effects of the medications, and also medical conditions. You then want to comment on the past psychiatric history, including hospitalizations, which may suggest vulnerability to occupational stress and less adaptive capacity. You also have to comment on prior outpatient treatment, if there was any prior to the job event and there's consistency across time, it may suggest that it may not be related to the job. You then want to comment on family history, including factors influencing early development and genetic susceptibilities, including things like suicide attempts, any major mental disorders, alcohol or other substance abuse in the family, or trauma. The past medical history is also an important component. You have to weigh in on medical contributions to the possible mental impairments. For example, things like thyroid disorders may actually be contributing to depression or anxiety, and you need to comment on that and how much of the extent that you think that it is contributing. For developmental history, you want to look at the parents' work experiences and behaviors and attitudes towards work, which sets an example for the patient. You also have to comment on any neglect and abuse, which may increase the risk of mental health disorders and may affect the prognosis for returning to work. You want to focus on educational history as well, including academic aptitude, school quality, parental support and resources, housing stability, and ability to sustain effort. For social history, you want to comment on marital history, any children and parenting responsibilities that they have. You want to focus on military history if there is any, if there are any Article 15 proceedings or less than honorable discharges that might suggest authority issues. So that would be important to comment on. You also want to comment on any legal history, including arrests and convictions, which may suggest an underlying personality disorder. And also these can limit job opportunities. DUIs may also point to substance use disorders. So you do want to hone in on any substance use history as well, which will reflect overall functioning of the patient. And then you want to really look into the social support of the patient and any leisure activities that they participate in, as it might give you a little bit more insight into the patient and the patient's personality and their ability to adapt. Then you want to do a full mental status exam, which is the same as any routine psychiatric evaluation, but you do want to examine them specifically for their ability to meet essential duties of their occupation. For example, really hone in on any cognitive deficits or cognitive testing for people who require that, including people who are in the airline industry. You also want to go through special considerations at the very end of the evaluation, including trying to find collateral if you're able to corroborate findings. In addition, you should always consider fraud and malingering in each exam. However, it is important to note that worker fraud is actually less common than employer fraud, and so just be mindful of that. And then you always want to be objective, and if you do feel like the patient is being deceptive, you need to maintain neutrality and then find evidence and support that in your report. To help support your claims or your report, you also want to always try to include psychological scales or any additional medical tests or labs that might be supportive of that. They do recommend the Minnesota Multiphasic Personality Inventory, which is often used in forensic evaluations. However, this does require special training. It doesn't always have to be included, but it might be something that might be helpful to include. Any prior or any scales that are self-reported or lack validity, like the BDI-2 or the PHQ-9, often are not viewed as reliable in forensic testimony, and so they're less relied upon. So just to be mindful of that as you complete your evaluation. Once you've done your full interview and your evaluation, you then have to do the summary, which is often written with a holistic style or quality. It should always try to evoke the personality of the examinee. You want to always focus on clarity and lack of jargon, as your audience is largely legal and not medical providers. You also want to address any questions that are posed by the requesting party, including the following: diagnosis, apportionment of causation, degree of impairment, whether it's partial or complete, any treatment recommendations, if there's been maximum medical improvement achieved, and can the patient return to work with or without accommodation, and would they benefit from vocational services? So that was a lot to go through. It was our longest section. I think it was hopefully one of the more informative and helpful sections of these presentations, as I feel like we don't really get a lot of training in this area as psychiatry residents. And hopefully it'll make you feel a little bit more confident going into discussions with your patients about going on leave or taking time off work, or even asking for impairment evaluations. With that, I will end for the day, and I hope this has been helpful. And yeah, I wish everyone the best of luck in their careers. Thanks. Welcome to part 7 of 7 of our organizational and occupational psychiatry topics for residents. I'm Parker Schwab, current PGY4 psychiatry resident. At the timing of making these videos, I want to thank my assistant author, Sam Gardner, and advisor, David Morrison, in helping create this curriculum. Before we begin, I don't have any conflicts of interest or financial disclosures. We will be using the term org psych to encompass both organizational psychiatry and psychology topics during this course, but please note that these fields are distinct. Today, we're mostly going to be talking about psychology topics. So to go over where we've been and where we are now, so this is the last part of a 7-part series. We've gone over what organizational and occupational psychiatry is in our first section. We then covered why it matters to us as practitioners, and then also why it matters to our patients. We discussed the U.S. Surgeon General framework for components of a healthy workplace, and then went over how to take a work history with our patients and how that might influence our treatment plans. And then we went over leave-in disability, both how to think about leave-in disability and then even how to perform those types of evaluations. And now we'll take a little bit of a detour into something that might be a little bit more fun, is to go through organizational psychology policies from the past and how they were both beneficial and maybe slightly controversial, and then also exploring how we can use that to think about where the field is going in the future and think key things that we need to think about going forward. So just briefly to start, we'll go over what organizational psychology is. It's a field dedicated to improving organizations and employee lives. It involves studying, developing, implementing, testing, and refining organizational interventions, which are defined as any planned change in policy, program, procedure, or system intended to shift employee attitude or behavior. So I put a couple example job types in this field. This is not exhaustive, but several examples include maybe being an in-house consultant for an organization, a treating provider for employees, and then maybe even working in academics and research. So traditionally, industrial and organizational psychologists, which is IO psychologists, have been involved in a range of benefits for workers over the last century, including developing policies such as intelligence testing, goal-setting strategies, and flexible work arrangements. However, there have been several unintended consequences of these that we should explore, including increased instances of unethical behavior, discrimination against minority groups, and then also reduced career opportunities for certain individuals. As you know, large organizations employ about half of the labor force, so you can see how these policies may have profound impacts on well-being of a lot of different people in our society. The first policy we'll go over is scientific management. This originated in the early 20th century by Frederick Taylor. It was designed to prescribe timing of tasks and eliminate waste. It was thought that it would boost worker productivity without raising costs. And then to do that, they would create incentive systems and pay workers according to the amount produced. I typically think of kind of like the Ford factory assembly line when doing this. That might not be a great example, but that's what comes to mind when I think about this. So, sorry, the lecture is going a little slow. Hopefully it'll move a little bit faster. So some of the negative consequences of scientific management is that it did prescribe mundane, repetitive tasks to employees, which increased the risk of physical injury and also increased the risk of developing mental health issues. In order to combat this, they did redesign this policy to help minimize injury. So, for example, they redesigned the height of a brick stand for certain bricklayers, which resulted in less back injuries. However, despite this, there was still a large public outcry in 1914. Congress had to form a committee to investigate this. There isn't much information on the outcome of this committee because it was so long ago, but I think this does kind of highlight that despite them trying to make modifications to it, people were still upset with this type of policy. The next policy is intelligence testing. So currently a majority of the Fortune 500 companies in higher education use some form of cognitive ability testing and applicant selection. A prime example of this is general mental ability, or what they call G. This actually has been validated by several meta-analyses and is an accepted tool used in employee selection systems that assesses developed abilities that are a result of innate talent, learned knowledge and skills, as well as environmental factors such as educational opportunities. And it's been shown to be predictive of individual performance across educational and work domains. But as you can imagine, it has caused some negative consequences, as average scores tend to be lower in minority groups or groups that don't have as many educational opportunities. It's led to numerous social consequences, including increased odds of discrimination. It's currently one of the most debated IO policies that's still in existence today. Forced drinking is the next policy we'll cover. So this was actually popular in the late 20th century and remains fairly popular today. It's estimated that approximately or greater than 60% of Fortune 500 companies use this practice in some form. Now there's a lot of mixed reception around it, as we'll go through some of the negative consequences of this. But forced ranking is when employees are ranked based on performance ratings from supervisors, They then reward a percentage of the top performers, including offering them bonuses or promotions, and then a certain percentage of the bottom performers are put on improvement plans or terminated from the company. This is often repeated annually to help clean house and allow for room for new talent. The negative consequences of this are that it may lead to decreased morale. It might be more perceived as more inaccurate and unfair by employers or employees. It may lead to increased lawsuits from employees towards the company, and then it may have an increased adverse impact on minorities as well. Goal setting is the next policy that was created by IO psychologists, which is the process of specifying objectives related to performance and planning steps of executing this. There's usually been a positive relationship between goal setting and task performance, and they've done studies that have shown that motivation increases when goals are specific, measurable, challenging, accepted, and also tied to specific outcomes. However, there are several negative consequences to this, including there may be decreased group performance if goals are focused on individual tasks. There could be increased risky decision making and unethical behaviors, which we'll show an example on the next slide. And then there's also potentially a risk of decreasing intrinsic motivation if goals are tied to group performance. So hopefully this will show up. Yep, here it goes. So we'll just watch a quick example of how this might go awry. It was the Wells Fargo scandal many years ago. We'll quickly just watch a couple seconds of this.
Tonight, the country's fourth largest bank, Wells Fargo, is paying up, agreeing to a $3 billion settlement with the Justice Department and the SEC after employees under pressure to meet sales goals created millions of fraudulent bank accounts between 2002 and 2016.
Simply put, Wells Fargo traded its hard-earned reputation for short-term profits.
All right, so I think that was a good example of how goal setting might incentivize people to take more risky or unethical decisions. The next policy is charismatic leadership. So this is a popular area of study in the 1980s and 1990s. There's a large body of evidence that shows a positive correlation with job satisfaction, motivation, performance, and innovation when companies are led by charismatic or strong leaders. Which then has led to the establishment of leadership development programs, which have been pretty popular in the last 20 years. However, there are some negative consequences with this. So it has been seen that some leaders can make poor decisions that may increase follower dependence on the leader of the company. There may be leaders who focus on personal achievement at the expense of others. And so organizations are strongly encouraged to consider leaders' individual values and motives before promoting them to positions of power. Group cohesion is the extent to which group members feel committed to one another. They've done meta-analyses that demonstrate positive correlations between cohesion, satisfaction, and performance. However, too much group cohesion can be negative, and that it may decrease productivity. There is a risk of groupthink, which is the tendency to agree with other members rather than objectively appraise. Many examples of this are things like the Enron, like unethical behaviors at Enron, the Challenger disaster, and then social media. I like to think of like echo chambers, where we kind of get sucked into thinking a certain way because we're only seeing certain viewpoints on social media based off of our likes. Bias training is another area of possible controversy. So bias training is the training that we probably all take every year at our companies, but for possible systems. But it's training to increase awareness of bias, prejudice, stereotypes, and attitudes. And overall, it's intended to make organizations more welcome of diversity. However, if this is not done correctly, it potentially may inadvertently enforce stereotypes. For example, sexual harassment training might increase gendered beliefs, could lead to decreased willingness to report harassment and may increase victim blaming if it's not done in a cautious way. Flexible work policies are policies designed to increase employee control of when and where they work. It includes things like compressed work weeks, remote work, flexible scheduling, and special leave of absences. There have been studies and empirical evidence that has shown that these policies can improve employee well-being and health. It can reduce costs and improve work-life balance. However, sometimes if people take leave of absences, this may be looked upon by the company as a negative, which may lead to less wage growth, fewer promotions, lower performance ratings. I like to think of maybe like a person taking time off for maternity leave, and then we all hear the examples of that leading to lower levels of promotions because of taking time off for maternity. So traditionally, IO psychology or industrial and organizational psychology is focused largely on the benefits of its policies and have not really focused as much on the possible consequences. And so now there's this call of need to maybe refocus the research on maybe the unintended consequences that we were going over today. The paper that I was reading proposed that there may be 7 social forces that are leading to us not really focusing on the consequences of this, 4 of which are internal to IO psychology, and then 3 are external to IO psychology. The 4 that are internal to IO psychology include causal attribution, which is just the statistical theory that like correlation is not causation. There may be adverse events that are related to confounders, not the actual thing that we're studying. And what makes this complex is that organizational policies occur in complex systems with many variables, and so it can be hard to narrow in on what might be contributing to the actual effect. There's also simplification bias, which is the tendency to reduce complex information into things that are more comprehensible or comprehensible. It's complicated by the fact that policies often studied are nonlinear relationships, which may require more complex statistical analysis that managers may not understand. And so it might be a complicating factor there. Theory mania is the fact that discovering new theories is more appealing than looking at old ones. And so there may be a bias there in terms of focusing our efforts on finding new policies instead of looking at the consequences of old. And then divided loyalties. So often in IO psychology, there's multiple stakeholders, including both the employer and the employee. And oftentimes those things are, those stakeholders have competing interests. And so it can be hard to navigate that as a researcher. So the other social effects that might be causing us not to investigate the side effects of policies is a marketing problem. So the focus on the side effects may skew public perception and maybe might make people not want organizational psychology policies anymore. There's also a lack of accountability. So things like a lack of regulatory agencies like the FDA for medications. There's resource constraints. So things like the fact that organizations are less willing to fund research that won't benefit them. So if they already have a policy that they feel like is benefiting them, why would they want to investigate potential consequences of that may lead them to not be able to employ that policy anymore? So in order to combat this and kind of move the industry forward or the field forward, they have several different recommendations in this paper, starting from reframing the question to then developing reporting systems, incentivizing research, establishing effect size guidelines, advertising known side effects to the public, and then educating future researchers are all things that they recommend to help advance the field. So the first one, reframing the question, this is moving towards trying to predict possible consequences before we even start creating policies. So maybe proposing each policy with the this type of framework. So if we do a certain intervention to accomplish a certain result, it might affect what, like what might be the consequences be. The next recommendation is to develop reporting systems. So that would include creating a database to report adverse events, similar to what the FDA does for medications. We want to incentivize research, so this means increasing funding for the field, developing journals dedicated to the study of side effects. We also want to establish effect size guidelines, which means that we want to map the frequency, intensity, and confidence of reported side effects to establish a risk level and stratify risk of each policy, and then also research the validity of these proposed risk stratification. In addition, we want to advertise known side effects. So that means informing all stakeholders of positive, negative consequences of policies, which allows for informed decision-making. And then also we want to educate future researchers of the need for additional research on consequences of these policies. So that was a little bit of a detour from what we've been doing before. I hope this was a fun exercise and got you thinking about more psychology policies that have been in place, and might kind of give you a better look as to the types of policies and structures within organizations that might be affecting our patients. This does conclude our curriculum on organizational psychiatry policies and topics for residents. I hope it was helpful for everyone. And yeah, I wish everyone the best of luck with their careers.